Welcome to the eFAST presentation. Hello and welcome everyone. Today we are going to embark on an exciting journey into the world of emergency, or also called extended focused assessment with sonography for trauma, or as more commonly known, the eFAST exam. This powerful diagnostic tool has revolutionized the way we approach and manage trauma patients, and we're thrilled to share this knowledge with you. This presentation is specifically designed for those of you who may have minimal or no experience performing the eFAST exam. We understand that ultrasound technology can seem daunting at first, but worry not. We've crafted this course with the novice learner in mind, breaking down complex concepts into digestible information. Before we dive into the specifics of eFAST, we assume you already have a basic understanding of an ultrasound machine. Our goal is to ensure you walk away from this presentation feeling confident and ready to apply these skills in your practice. The objectives of this presentation are to understand the basic components of the eFAST exam and to be able to identify key structures when you're doing the eFAST exam. These include diaphragm, liver, spleen, kidneys, the lungs, bladder, uterus, Morrison's pouch, the pelvic cul-de-sac. You want to be able to identify free fluid in the abdomen and pelvic area and what it looks like. And then you want to be able to identify indications of a pneumothorax, hemothorax, as well as pericardial fluid. Most importantly, cardiac tamponade. The indications for the eFAST exam include blunt and penetrating chest and abdominal trauma. Your goals are really to detect hemoperitoneum, detect hemopericardium, and detect a pneumothorax. It's important to say we're not trying to quantify here exactly what the heart's doing or where the bleeding is. You just want to detect if it's there or not. And really the only contraindication is you don't want to delay time-sensitive care because you're doing the ultrasound and FAST exam. For example, when I'm flying, if I have a patient who's clearly bleeding, who clearly needs the operating room, doing the FAST exam and delaying care is not necessarily the best thing to do. So the first choice you need to make is what probe are you going to select. And remember, eFAST is generally done in an emergent situation. If I had to choose one probe, I'm going to choose the phased array. The reason I choose that probe is it can accomplish all the goals of the FAST exam, including you can look around the heart for pericardial fluid. You can look in the abdominal cavity for potential bleeding there, and then you can also use it for lung sliding. That said, if you're looking in the abdominal cavity, you can use the convex probe, and if you're just looking for lung sliding, you can use the linear probe. A quick review on terms and echogenicity. So remember, echogenicity is just the ability to reflect an echo. Hyperechoic, so white structures, such as the spine, which we'll talk about later, are going to be bright, whiter. Isoechoic, these are going to be your muscles, your tissues. Anechoic is what you're looking for when you're doing the eFAST. We are looking for fluid. Free fluid is anechoic. It doesn't reflect echoes. So when we're doing the eFAST exam, we're looking for anechoic, black on the screen. We're looking for fluid in the abdomen. The exam can be done in any mode, but remember that abdominal mode and cardiac mode, you can get the same image, however the indicator is going to be 180 degrees opposite. The best choice is to select abdominal mode, and we're going to talk about the eFAST exam done in abdominal mode. I'm going to start off with key structures you should know, and then we'll go over each of these. And my hope is that the repetitive visualization of the structures will ingrain these findings in your brain. So first, liver, diaphragm, kidneys right here. This is the spine. Note how the spine doesn't carry through, and there's a reason for that. This is actually the lung, and we're going to talk about why in later slides. Abnormalities you should know. So again, this is the liver. The patient's head is up here. The patient's feet would be down here. This is the kidney. This is the spine. And this is free fluid. This particular view, it's blood in Morrison's pouch. All right, so what is the eFAST exam? So eFAST, it used to be called the FAST exam. So FAST stands for Focused Assessment with Sonography for Trauma. And basically we're looking at 4 areas when we do the FAST exam. We're looking around the liver, we're looking around the spleen, we're looking around the pelvis, and we're looking around the heart, and we're looking for free fluid. The E, so the extended part of the FAST exam, we're looking for lung sliding. And our goals here again, look for fluid around the heart, look for fluid in the abdominal cavity, make sure there's no pneumothorax. These are your windows that you're going to look at. So looking lung sliding here, right upper quadrant view is here, pelvic view is here, left upper quadrant view is here, and then the subxiphoid view is here. Remember, free fluid. Free fluid over here is the most common finding with acute hemorrhage. Free fluid is black. Here we have free fluid around the heart. However, depending on when the hemorrhage occurred, that can start to form clots over time. So you may find echogenic findings. This looks like free fluid here around the heart, and then this echogenic finding is indicative of clotting starting to form. So I like this slide because it illustrates the path that blood will travel when you have bleeding in the abdominal cavity. So notice that if there's hepatic hemorrhage here, blood can move down the right paracolic bladder, and then pelvic fluid will also move this way. Much of this is depending on the way the patient is laying. And then notice how also with the large splenic hemorrhage, blood will travel this way, come across, and go down the right paracolic bladder. So the point of this slide is if you had one view, time is very limited, I would choose the right upper quadrant view. Because if you have a large splenic hemorrhage, you'll catch that here. If you have hepatic hemorrhage, you'll catch that here. And also a large pelvic hemorrhage, you'll catch that here. Now that's not to say that the FAST exam will catch all bleeding, because if you just have a small splenic hemorrhage, it's not going to come across and you may not see it. But with a large intra-abdominal hemorrhage, I would choose the right upper quadrant view. And once that was positive, you really have identified that there's blood in the intra-abdominal cavity. So here's a quick overview of how everything will look if there's bleeding in the abdominal cavity. So this black, again, this illustrates the path of fluid flow. So your right upper quadrant view, which we'll go over in detail, the patient's head is here, feet are here. This is the liver, this is the diaphragm, this white area is the spine, this is the kidney, and here is anechoic fluid, suggesting intra-abdominal hemorrhage. The left upper quadrant view, so looking over here, anechoic fluid here, so this is the spleen here, so likely a hemorrhage around the spleen. And then looking at the pelvis, so this is a full bladder here, and this is intra-abdominal hemorrhage in the pelvic area. So your first view, the first view we'll talk about is the right upper quadrant. Again, why? Because this is the most likely area to detect hemorrhage, and most large hemorrhages you will detect here anyway. So the indicator should be point towards the patient's head, and what you're doing is you're looking into the body, and we're looking for an area called the hepatorenal space, more commonly called, at least in the United States, Morrison's pouch. And most literature will tell you to look between the 8th and the 11th rib. However, in reality, what you're going to do is you're just going to put the probe on the patient, indicator towards the head, maybe angled slightly so you can get between the ribs, and you're going to start scanning and looking for structures that are familiar. Here's another illustration. Again, this is done in the coronal plane, so we want to identify three key things. Number one, we want to look around the diaphragm. We want to look at Morrison's pouch, again, because this is the area most likely to collect hemorrhage. And then we want to look at the tip of the liver. And the reason we look for all three is when we look around the diaphragm, we're also looking for hemothorax. Again, Morrison's pouch, because this is the most likely area for blood to collect. And then the tip of the liver, so you can truly call the exam negative. However, I have learned, just report your findings. If you don't see blood, say as such. I would use caution calling any exam negative. So again, patient's head is here, the patient's feet are here, probe is pointing this way. Notice that we're aiming towards the spine here. So the liver is there. Diaphragm is here. Lung is here. Kidney is here. This white area is spine. So think to yourself, on the normal person, the spine travels all the way up here. However, we do not see it here. And there's a reason for that. So if I turn my head and I talk, sound waves, you can still hear me, but sound waves are scattered. So what happens is the probe sends out sound waves, they go through the diaphragm, and they kind of get scattered. And there's no real clear image of the spine. This is actually called, this is mirror artifact. So this is the lung. However, what you're seeing is kind of a mirror image of the liver. And take note of that because, and think to yourself, what would you see if there was fluid here? So this is the right upper quadrant, perihepatic view, patient's head, patient's feet. This is the liver, kidney, the spine. This is blood in Morrison's pouch, anechoic area here, and a little bit of echogenic or isoechoic area here. So this is likely bleeding in Morrison's pouch and maybe some clotting here. Now, I consider this nice to know information, but it's good to know, so we'll talk about it. So remember, around the kidney, there's this fibrous tissue called Gerotis fascia. So that would be this area here. This is the liver, the kidney. This is fat, but this is gyrotous fascia. And really, peritoneal fluid will be above gyrotous fascia and Morrison's pouch, and then retroperitoneal fluid will be below that. Here's an illustration of that. So hemoperitoneum here, this is the liver, this is the patient's head, patient's feet, here's the spine, here's the kidney. So retroperitoneal hemorrhage, peritoneal hemorrhage. I think from our standpoint, either way, this patient may need the operating room and is bleeding in the abdominal cavity. So here's some abnormal findings again. Patient's head here, patient's feet here. This is the liver. This is the spine. And notice, remember on the other images, the spine was not there. However, we see it. And the reason we see it, sound waves travel through the diaphragm here. They don't get scattered. They go through the free fluid. They hit the spine and then reflect back. So this is called the spine sign, and this is indicative of fluid around the lung in the setting of trauma, hemothorax, in the setting of a medical diagnosis. This could be a pleural effusion. Hemoperitoneum here, so patient's head, patient's feet. We know we're in abdominal mode because of the indicator here. Reminder, these are this is your depth marker. Spine's here, the kidney's here. This is the liver. Here's blood in Morrison's pouch all around here. So this is a positive FAST exam. Here's a hemothorax. So liver here, the spine, and note again how the spine carries through. There's fluid right here. I like this slide because it's going to highlight the importance of sweeping. And when I say sweeping, what we do when we scan is we're not just looking at one area for hemorrhage, we're looking through, so we're sweeping through the body, scanning for bleeding, scanning for free fluid. Here's the patient's head here, here's the feet. So again, the liver here, I don't see any hemorrhage. Here's the spleen. We're looking at Morrison's pouch here. This looks like there's no obvious hemorrhage. However, we're going to play this video and notice how the bleeding becomes apparent. A word of caution when you are scanning the right upper quadrant is remember the gallbladder is located on this image. So if your probe is angled too far anterior, you're going to catch the gallbladder and it may look like a hemorrhage. So you want to keep the kidneys, the spine, and the liver all in one view to avoid that error. All right, the parasplenic view, so the left upper quadrant view. So here we're simply looking around the spleen. And again, the literature will quote 8th to 11th ribs, slightly oblique in line with the ribs. I would not count ribs. What you're going to do is you're going to put the probe on the patient, and again, you're going to start scanning the indicators towards the patient's head, and we're looking for free fluid. Take note here, compared to the liver, the spleen is a lot smaller and it's more posterior. So clinically, this is a little more difficult to find, and your probe is closer to the patient's back, closer to the bed, and you're angling up just a little bit. You don't want to catch too much and catch the stomach, but just a little bit. Again, looking for free fluid. Looking around the diaphragm again. Why are we looking around the diaphragm? Well, we want to also look for hemothorax, and then we're looking at around the spleen, again, looking for hemorrhage. Generally in the coronal plane, the way this illustrates, we're pointing down, and that's not the case. You're going to kind of come in from the side of the patient, sound waves angled up slightly, so a little pointed anteriorly. This is a normal image. Spleen is here, the diaphragm's here, the kidney's here. Again, note how the spine is here, but you don't really see it here, and that's a sign of no fluid in the lung. I like this image as well. So again, the spleen's here, and a couple things to highlight. If you angle this probe too much, you may catch the stomach. Inside the stomach, there's fluid, and that can confuse early learners that there is hemorrhage, when in fact it's just fluid in the stomach. Also note on the spleen with this image here, so the most dependent area on the spleen would be this area here. So what's that translate to when you're actually scanning a patient? So if the probe's here, the free fluid is going to be closer to the probe. So most often, splenic hemorrhage will be kind of near the top of the screen, closer to the probe. And also beware here again, you don't want to catch the stomach. So this is stomach contents here, and that can be confused for early learners as hemorrhage, when in fact it's not hemorrhage. So bleeding, we'll show images of this. Bleeding would be kind of in this area here, most likely. Here's an image that highlights how free fluid tends to be above the spleen. So patient's head is here, patient's feet's here. So here's the spleen. Notice all this anechoic area here. So this is indicative of a splenic hemorrhage. Again, look how the spleen's here, and the free fluid tends to collect closer to the probe, so that the top of the screen. Here's a little video clip of another splenic hemorrhage. So this is the spleen here. There's free fluid there. There's the kidney here. Here's the spine. Remember, when you look at the spine, you want to also look at the diaphragm, and we do. And we can see the spine sign here, and there's some free fluid here. So this is splenic hemorrhage. And there's also a likely hemothorax. I do want to note that often when you're scanning on the left upper quadrant, there's a rib. If you look here, there's a rib here and there's a rib here when you're scanning, and that can create what's known as rib shadowing. So that's what you're seeing, this little black area here. That's rib shadowing artifact, and also there's some rib shadowing here. Again, when we're doing the FAST, we're just trying to diagnose hemorrhage or not, hemothorax or not, and we make that diagnosis, and you can be done scanning and move on to definitive treatment. Here's another video clip. The patient's head's here, the feet are here. Here's the spleen. There's a large splenic hemorrhage here. The kidney's coming in view here. I see the spine here, and it looks like the spine travels here, so this is likely as well. Hemothorax, splenic hemorrhage. It's kind of hard to see, and really the move is you've identified hemorrhage here. I would focus the probe this area and to identify whether or not there's hemothorax. Here's a clear hemothorax. So I'm not really focused on the spleen. We're not imaging the spleen here. Let me play this video again. So clear hemothorax here. Here's the spine. This little area here is actually the lung, and there's fluid all around the lung. So here's a hemothorax in the setting of trauma. If this is a medical patient, it could be a pleural effusion. All right, so we've scanned the right upper quadrant, looked around the liver, the left upper quadrant, we looked at the spleen, and now we're going to look at the pelvis. So we look for what's called the pelvic cul-de-sac. Cul-de-sac is just French meaning the bottom of the sac. And again, we're looking for the most dependent area, and our eyes are going to where blood is likely to travel. The transducer is placed midline, just above the symphysis pubis, and the indicator will either be facing towards the patient's head or towards the patient's right. So here's the anatomy of the cul-de-sac. In the females, it's called the cul-de-sac. In the males, it's called the retrovesicular space. And again, this image flipped, we'll be scanning from this area through the bladder. We're looking here, and we're looking here. And this is kind of how the ultrasound probes. So indicator towards the patient's head, and indicator towards the patient's head. Now there's a long axis view and there's a short axis view. Again, you just want to identify the blood. Once you've identified the bleeding, you can be done. So this is either done in the sagittal plane or the transverse plane. Now, something to highlight. If you do the short axis view, so the short axis would come, your line of sight would just be this way. So what can happen if you only do the short axis view and your probe is angled too much towards the patient's feet, you can miss intra-abdominal hemorrhage if you didn't scan enough. So I prefer the long axis view because the sound waves come out this way and you can scan. However, you can do either or both. Here's a long axis view of a female. So the patient's head is here, the patient's feet is here. Here's a full bladder. Now keep in mind, in the setting of trauma, the bladder can be ruptured, so you may not always have free fluid here. Here's the uterus, here's the pelvic cul-de-sac, and this would be a short axis view. So we would be looking, this is the indicators towards the patient's right. Here's the bladder, here's the uterus. Here's a long axis view. In a female, the patient's head is here, the feet are here. Here's a bladder, the uterus, and then some free fluid here in the pelvic cul-de-sac. Another long axis view. The hemorrhage is starting to progress. So this is the patient's bladder. Free fluid here, free fluid here. Here's another image of a patient with hemoperitoneum. So the bladder's here, the uterus is here, and then we have free fluid here and free fluid here. Short axis view, free fluid here, free fluid here. Here's a male, normal male, no free fluid here. This is the bladder, the prostate gland, the seminal vesicles are here. Again, the patient's head is this way, the feet are here. Here's a short axis view, so the indicator is towards the patient's right. Here's the bladder, full seminal vesicles. I would be less concerned with memorizing exactly what the structures are. Again, we're looking for free fluid. Here's a full bladder here. This is a long axis view, so the patient's head is this way, the feet are this way. This is intra-abdominal hemorrhage this way here. There's a short axis, so again, the indicator's towards the patient's right. Here's the bladder. Seminal vesicles here, and then free fluid underneath. I feel it's easier to identify in the long axis view. Hemoperitoneum in a male. Notice where the arrow is pointing. It goes to all the intra-abdominal hemorrhage. These happen to be bowel over here. Next, we'll talk about pericardial scanning. And remember, our goal here is not to identify ejection fraction or abnormal structures. We're just looking for fluid around the heart. If it's there, then we ask ourselves, how big is it, and is it causing hemodynamic compromise with cardiac tamponade? The transducer is placed just below the xiphoid process, below the sternum, and angled upwards towards the heart under the costal margin. Now, you're going to see how we can roll through the liver and find the heart that way. I have found to just kind of visualize where the heart is and imagine that you're holding some sort of flashlight or something and just pointing towards where you think the heart is works the best. However, this may be different for others, so we'll show you several ways. So here's a nice video. Notice how we can see the indicator here towards the patient's right, and they're going to roll. We're looking through the liver. The hand's going to come down, and the heart will start to come into view. RV is here, RA is there. This is the LV. And we're looking for fluid around the heart, which I will show you some nice images of. RV, VRA, the left ventricle, the left atria, the pericardial sac. This is the liver here. This is a good image. There's no fluid around the heart. Here, in the setting of trauma, this is hemopericardium. This could very well in a medical patient be a pleural effusion or pericardial effusion. We just don't know. And the important thing to notice here is how the right ventricle is starting to collapse in. So the reason it does that is you have a high pressure outside of the RV. This pressure is pushing the RV in. It's kind of hard to see, but the RA also starts to collapse in a little bit. But what this is telling you as a clinician is this guy has no preload. This is an emergency, and this may warrant emergent thoracotomy. Somehow, somebody has got to get this fluid out. I want to highlight the difference here between a epicardial fat pad and effusion or potentially hemopericardium. So notice on a epicardial fat pad. So this is fat tissue that's on the heart. Notice how it doesn't travel all the way around the heart. Generally speaking, when you have fluid around the heart, you're going to find that the fluid will travel all the way around the heart. So be careful, especially in larger obese patients, when you're looking around the heart. If you have a finding of a fat pad, I've made the mistake, I'm sure other people have too, is you can confuse a fat pad for a echogenic effusion or a hemopericardium, and it may look like clotted blood. Either way, what's important to note when you do have an effusion is you want to look at the RV here and look for collapsing in, because that's going to tell you whether it's causing hemodynamic issues. Here is a pericardial hemopericardium or effusion, depending on the setting. We know there's fluid around the heart, so this is the liver up here. You have fluid all around the heart, and then look how the RV is collapsing in. And then you generally, actually the first indicator will be the RA will collapse, but you're looking at the right side of the heart, and if it's starting to cave inward, it's telling you that there's hemodynamic compromise. Now we're going to talk about the E, so the extended part of the FAST exam. And really our goal here is to rule out a significant pneumothorax. I think this is a good time to remind people that, remember, any positive pressure, whether that's CPAP, BiPAP, intubation, any positive pressure will reduce a patient's preload. Especially attention pneumothorax, which I'll show images in a second, but this positive pressure reducing preload is even more dramatic on a patient who is volume depleted or in the setting of trauma who may be bleeding. So our goal with the eFAST is to rule out a pneumothorax, because if we see a pneumothorax, it doesn't necessarily mean we need to intervene, but we will be very cognizant of any positive pressure we apply, or if there's hemodynamic compromise, we'll have an idea of where we might want to intervene. And remember, attention can happen on either an open pneumothorax or a closed pneumothorax. So we have pressure, air, collapsing the lung and reducing preload by collapsing on the inferior and superior vena cava. I also think it's a good chance to play this video, and I thank this doctor for posting it online. Here is a large pneumothorax, and you're going to see, this isn't the actual image, but you're going to see what happens when a needle, or this lung, when there's a needle decompression. Notice the delay with this. I don't know the size of the angiocath. There is a delay, it's taken a while for the lung to re-expand, and this is a discussion for another day, but a chest tube would evacuate that pneumothorax much faster. So our goal, again, when we're scanning the lung in a eFAST exam, is we're looking for, or at least we want to rule out a pneumothorax or significant pneumothorax. Here's the indicator. This is the linear probe, but this can be done on the phased array probe as well, and even the convex probe. And here are the indicators towards the patient's head. Here's a rib. There's a rib there. And this is the pleural lining. So no pneumo here. Remember, hyperechoic, so white on the screen, is caused by more dense structures. So what you have when the lung is up is the parietal and visceral pleura moving back and forth on each other. So you can see the little calcifications. They call this ants marching on a line. That's telling you that the lung is up. You don't see that when there's a pneumothorax. Now, the truth is, if there are adhesions or there has been some sort of surgical procedure to fuse the linings together, you may not see lung sliding. But in the setting of a trauma, we can presume that if there is no lung sliding, it's suggestive of a pneumothorax. It doesn't mean there is a pneumothorax, but that is definitely suggestive of a pneumothorax. This is live. Remember 2D mode here, and then you're going to see they are putting this into M mode, and this is motion over time, and we'll talk about the findings you'll see there. So again, on this, when the lung is down or presumed to be down, the parietal and visceral pleura won't be together, so you're not going to see lung sliding. So the image on the left is the same. The image on the right is no pneumothorax, but I want to discuss another finding. So you'll hear the terms A lines and B lines. So B lines, also called comet tails, this is a patient with pulmonary edema. So they're more pronounced when there's fluid in the interstitial tissue of the lung. So these comet tails or B lines are telling you that this lung is up. You can kind of see them here. So those are comet tails or B lines. And then also the lines running this way are termed A lines. And what these actually are sound waves coming down, reflecting, going back, hitting the probe. So these A lines are actually reverberation artifact that's seen, and you'll see they kind of fade out over time. So A lines are here, and then B lines, also called comet tails. It's the B lines and comet tails that are telling you the lung is expanded. And here's a nice illustration of what creates the A line. So the sound waves go back, they keep on traveling back and forth and kind of fading out over time. So you'll see that here. These are the A lines. Now M mode, clinically, you do not need M mode to tell you that the lung is up or there is potentially a pneumothorax. However, for documentation purposes, this is motion over time. And what you're going to see is they call this finding sand on the beach. So you have the sand here, this little grainy area, that represents movement. Here, so you have the beach, the seashore, and then the sky here. They term this, and suggestive of a pneumothorax, the barcode sign. So for documenting, you can record your findings. So the way to rule in pneumothorax is you may hear a term called lung point. So here is lung point, and what you're seeing is the lung is moving here, and then at some point it becomes, there's a pneumothorax. So air separates the parietal and visceral pleura here. So this is actually suggestive of, or can rule in, a pneumothorax. I would not spend time looking for lung point. That just delays definitive care. However, if you're trying to quantify the size of a pneumothorax, you can use what are called zones. Now, these zones are labeled differently in different textbooks, but the concept here is what's important. So if you put the probe on the thorax up here and there's no lung sliding, you're going to ask yourself, well, first you're going to say, maybe there's a pneumothorax there. And then the next question is, how big is this pneumothorax? So the way to try to quantify that is to take it from zone 1 to zone 2. Clinically, you're just kind of going more posterior, and you are saying, no lung sliding here, no lung sliding here, no lung sliding coming from this way. That's a pretty big pneumothorax, versus if you just had no lung sliding here anteriorly, but there was lung sliding here, that could potentially be a smaller pneumothorax. Here's lung point captured in M mode, so barcode sign here, suggestive of a pneumothorax here, and then this captures the lung point on M mode. Finally, if you see any movement at all, this particular movement is called lung pulse. So this is telling you, and this is only going to be found generally on the left side, but it takes an inflated lung to transmit the movement of the heart up here. So if you see lung pulse, this is also telling you that that lung, or that area that you're looking at, is up and there is no pneumothorax there. Okay, quiz. Free fluid on ultrasound will be what echogenicity? And that's anechoic. In other words, free fluid will appear black. You should know these areas. This is the patient's head. Indicators towards the head, we have the abdominal mode setting. This is the patient's feet. This arrow is the liver. This is the diaphragm. This is the kidney. Here is the spine. And we are saying to ourselves, I do not see the spine carrying towards the head, but I know it's there. We're seeing mirror artifact. So this lung is up. There's not a pleural effusion. There's not a hemothorax here. Which image below is suggestive of a pneumothorax, and how do you know that? The answer would be B is suggestive of a pneumothorax. A, the lung is up, and the reason we know the lung is up is because this is the sand on the beach, so there's motion here. This is the barcode sign.